We will continue with the guideline presentation. So this evening we are having guideline on pericarditis, atrial fibrillation. Then there will be a small talk on what is new in pulmonary embolism. So we are going to take the first guideline now by Dr. Odonye Augustine. Dr. Augustine, you can start. I hope we'll be able to do
Okay,
it
good
under
evening to
5
okay, to be
minutes.
short, don't worry, maybe 20 minutes. Okay.
Oh,
Good evening to
thank
the
you.
house. Apologies, it should be guideline on pericarditis disease. I just saw it myself. That's not is a pericarditis that is on it. Okay. So we are all familiar with pericarditis. It's due to inflammation of the pericardium, basically. But going with the guideline, they actually stratify pericarditis into 4 categories. So we have the acute, incessant, recurrent, and chronic, and then each of the 4 are properly defined. For acute pericarditis, it's said to contain at least two of 4 criteria. That the patient should have a pericarditic chest pain. Patient should also have a pericardiac rub, which when we listen feels like walking on the snow, the way it's described. Then new widespread ST segment elevation, which are usually saddle shaped or PR depression on ECG, and pericardiac effusion, which might be a new onset or is worsening. Maybe the first time was a mild effusion, is now moderate and severe. So any two the patient has will qualify them to be tagged as having acute pericarditis. So in addition to that, also the biomarkers, the C-reactive protein are also considered.
You just want to get that slap people ask offline. I swear.
But in particular, the C, but in particular the C, yes, which also help in monitoring of the treatment. And evidence of pericardiac inflammation by imaging technique are also being considered. So for incessant pericarditis, it's tagged as a pericarditis lasting for more than 4 to 6 weeks, but less than 3 months without remission. Okay, lasting for more than 4 to 6 weeks, but less than 3 months without remission. However, recurrent pericarditis is a recurrence of pericarditis after a documented first episode of acute pericarditis and a symptom-free interval of 4 to 6 weeks or longer. Okay, 4 to 6 weeks or longer for recurrence. Okay, then for chronic pericarditis, it's pericarditis lasting more than 3 months. Okay, so there's a triage for acute pericarditis, and the first part, the upper part here, dwells more with an investigation and a physical examination. So physical examination might help us to pick extra things. So basically for straightforward acute pericarditis, you might not pick anything extra on examination, apart from maybe able to demonstrate if the pain is relieved with leaning forward or worsening with lying down. But however, if it's getting complicated, like having pericardiac effusion and it's getting complicated with possibility of interpulmonary physiology, they might be able to pick quite a number of things. And depending on the size of the effusion, also might be able to pick a number of things. So physical examination is critical, and the ECG is also important to help us look out for ECG changes that will be in support of acute pericarditis, like we earlier said. Chest X-ray might usually be normal for just straightforward acute pericarditis, but when it's getting complicated and there's accumulation of fluid in the pericardial and the pericardiac space, then we can possibly have in this bottle-shaped appearance on chest X-ray. And also your echo will be very important to help you see if there's accumulation of fluid. So some patients can have mild effusion, moderate effusion, and pericardiac effusion. And also the CRP, very important in managing a patient with acute pericarditis. It helps us to monitor treatment. Okay, if the values are dropping, then it's suggestive of how do I put it now? That the medications we are given, the anti-inflammatory medications are working. And if it's the opposite, it means I might need to take a second look at what we're doing. And then troponin is also important to differentiate from ischemic pain. So does your patient have pericarditis? If the answer is no, then you need to look for other diagnostic criteria that are not satisfied and search for alternative diagnosis. However, if your patient seems to actually have signs suggestive of pericarditis, the investigations are pointing towards that direction. So that means you need to actually commence treatment for this patient. And then, however, factors that may actually determine whether you keep the patient or ask the patient to go home will depend on the prognostic factor. If the patient has a poor prognosis, which are on the table, fever more than 38, acute onset disease condition, like pericardial effusion, a tamponade physiology, lack of response to aspirin or NSAID, at least after 1 week of therapy, then those are regarded as a poor prognostic factors. And the other minor ones are also stated there. So for patient who doesn't have, for patients who do not have what is your poor prognosis, you might start them on NSAID and watch them respond. So if they respond well, it might be low risk case, but if they're not responding well, then you might need to admit and search for etiology. So for the medications, basically, we need to go above the usual doses of most of these medications. The aspirin is said to be about 750 to 1 gram, 1 milligram every 8 hours for 1 to 2 weeks. And the ibuprofen, which is usually given 400 for somatic pains or other pains in the body, it needs to be jacked up to 600 milligram every 8 hours for almost 1 to 2 weeks also. And the colchicine is also an add-on for treatment of pericarditis, which in the instance of acute pericarditis should be given for about 3 months. Okay. So just a therapeutic algorithm for acute and recurrent pericarditis. So for the upper part, does more for diagnosis of and management of acute pericarditis. So for acute pericarditis, aspirin or NSAID, colchicine, and the exercise restriction. For non-athletic people, but for athletic people, said that the restriction should be up to about 3 months. Then the second line drug, if there are contraindications to aspirin or NSAID, the patient will benefit from low dose corticosteroid. And in case of contraindication, basically, and after excluding infectious disease, we can go ahead with the low dose corticosteroid. However, for patients who have a recurrent pericarditis, they are symptom-free for 4 to 6 weeks before they begin to feel symptoms and signs suggestive of pericarditis. They're said to have recurrent pericarditis. So we can also put them back on the aspirin, NSAID, plus colchicine and exercise restriction. And then if there are contraindications, we can do steroid. And the third line is now said to be intravenous immunoglobulin, anakinra and azathioprine, which are also can also be exploited. And if there are no response, then we may be looking at pericardectomy for this group of patients. So this is just a little algorithm for pericardial effusion if the patient has a cardiac tamponade physiology or suspected bacterial or neoplastic etiology. So if the answer is yes, a pericardiocentesis will be required to relieve the pericardium of excessive fluid causing collapse of the ventricle and the atrium, as the case may be. But so on the other side, check out for elevated inflammatory markers. Okay. So for those who have inflammatory markers, the ESR, the CRP. Hey, Jesus, my battery is low. Sorry, I hope we can go through. Okay. Pericardiac. Sorry. Okay. So for those who have elevated level of CRP, empiric anti-inflammatory therapy, as we said earlier on, will be helpful. And then for those who don't have that, you may also need to look out for if there's effusion. So for those who have pericardial effusion with properly related disease, you can also treat this disease condition. Right? People having SL example now, also manage the SLE, which also will help to slow down progression of the complications. And for those who do not have effusion as large as 20 millimeter, you can just put them on follow-up. And for those who have, you can consider pericardiocentesis and drainage if chronic. Okay, so for the ESC guideline, for investigation and then treatment simultaneously, let's start with the investigation. So ECG is a class 1 recommendation. A transthoracic echocardiograph is also another class 1 indication. Chest X-ray is recommended, which is another class 1, and then the CRP to help us manage the progress in also another class 1 recommendation. For the treatment, like we said earlier on, aspirin NSAID is another class 1 recommendation, and colchicine for the first 3 months is also another class 1 recommendation. Okay. So for patient with recurrent pericarditis, it's still the same pathway, but the different thing here is just that after starting on aspirin and NSAID, okay, the colchicine, instead of being 3 months, will now be 6 months now. So it's 6 months, used for 6 months in instances of recurrent pericarditis. And it's even said that the colchicine can be longer than 6 months, with respect to the response of the patient. So you can even push a bit above 6 months for those group of patients. And your CRP is also important to guide treatment duration. Okay, if the levels are still a bit high, you might still want to continue your colchicine for extra 1 or 2 months, basically. And so they also made mention of this second line, or the third line drug again after you've given a steroid a try. You can also use intravenous immunoglobulin, the azathioprine, and the exercise restrictions in them. Okay, so that's it. So for a patient who has recurrent pericarditis and there's also possibility of ischemic heart disease, it's advised, though a class 2A recommendation, that you might need to increase the dose of the aspirin you're giving to medium high doses. Okay. Am I still audible? Let me check. Please let me just check the level of the battery. I want to know if I need to put it back up. 1 minute, please. Okay, 9%. Can you just give me 1 minute, please? Let me just pause. Let me just so that doesn't go off, please. 1 minute.
All right, sir. Please, can we pause the recording?
So also, I also checked the American guideline, the American College of Cardiology, and they also followed the laid down. They also followed the laid down diagnostic criteria by the ESC, basically just to emphasize the extra things that they talked about. So they still agreed with what the ESC outlined, which we talked about earlier. Earlier. Okay. However, for recurrent pericarditis to be diagnosed, they said that patients should meet any of these 3 criteria: documented episode of acute pericarditis, and symptom-free interval of 4 to 6 weeks, and recurrence based on criteria described as acute pericarditis. However, patients with recurrent pericarditis having a recurrence of chest pain often do not meet the other listed criteria. So it's advised in such instances that diagnosis is supported by actually checking out for the ESR and the CRP levels. And they're also trying to make a strong emphasis about considering imaging studies, the CMR and the CT, to make assessments for those group of patients. So in the absence of disease-specific inflammatory markers, according to the American College of Cardiology, data have rapidly evolved, supporting the use of imaging in pericarditis, and the guidelines recommended echocardiography as a first-line imaging test for all pericardial diseases. And the other imaging modalities, such as the CMR, have traditionally been reserved for unclear cases. However, lead CMR sequencing has been used to provide pericardial characterization by detailing the anatomy and quantifying the pericardial inflammation. So the presence of a T2 and late gadolinium enhancement has a sensitivity of 73 and the specificity of 99% for diagnosing recurrent pericarditis. Okay, so the summary of the on the ACC is that up to 30% of patients with acute pericarditis can have recurrent pericarditis, which can be remarkably difficult to treat, and the treatment duration could last up to 5 to 7 years in patients with multiple recurrence. Then, since the last published guideline is 2015, there has been tremendous growth in data supporting the use of advanced imaging and biologics for management of recurrent pericarditis. And lastly, the CMR imaging and the interleukin inhibitors form the backbone for individualized treatment of a recurrent pericarditis, which has led to a paradigm shift by considerably decreasing the total treatment duration. Okay, so this is just the outline is also similar to what we talked about on. Just putting emphasis on that. Initially, when you make an assessment of acute pericarditis, you can see this obvious shining pericardium at this point. But as the disease progresses, the pericardium becomes fibrosed, and for the imaging part, it's less visible like that due to fibrosis. But just as a form of summary, they still also encourage NSAID and cortisone for 3 months for acute pericarditis, and then for recurrence, like we said earlier on, the NSAID can still come to play with cortisone for 6 months or more, depending on patient response. And for second and multiple recurrence, NSAID, cortisone, and then the CMR and CRP are also advised to be put in use. And then for and this is like the second and multiple recurrence. So looking at the level of the CRP, for low CRP and the negative gadolinium enhancement, they advise steroid. However, for high CRP and the positive gadolinium enhancement, they're looking at interleukin-1 inhibitors over steroid, basically. And for recurrent pericarditis, the endpoint, which was also suggested by the ESC, is to have a radical pericardectomy. Okay, so looking at steroids, they are not usually advised to be used. They are reserved for patients with persistent symptoms despite first-line therapies, or patients with contraindication to NSAID or cortisone. So even though they tend to provide relief of symptoms, there are 3 main concerns with use of steroids, which is associated with 1, increased risk of recurrence of pericarditis, prolonging disease course, and the steroid-related side effects like weight gain and muscle loss, okay, issues. And then when used, low to moderate doses are encouraged, and then immunosuppressive agents like methotrexate, intravenous immunoglobulin, azathioprine are also indicated third line for recurrent pericarditis. Okay, so for pericardial effusion now, they're classified based on the onset, acute, subacute, and then chronic. The size, less than 1 centimeter, which is equivalent of 10 millimeter, is mild. 1 to 2 centimeter or 10 to 20 millimeter is moderate, and more than 2 millimeter or 2 centimeter is severe. And the distribution, this circumferential, is it loculated, and the composition of the effusion is also important. Is it transudate or exudate? Okay, so straight to the diagnosis, using of a transthoracic echo is class 1 recommendation. The chest X-ray is also a class 1 recommendation, and then assessment of markers of inflammation, CRP, is also another class 1 recommendation. And even though the both the ESC and the American College are also pushing the use of imaging, which is still a class 2 recommendation here. Okay, and for management of effusion, it is recommended to target the therapy of pericardial effusion at the etiology. What's exactly causing the pericardial effusion? Then 2, for the recommendation, still to treat as pericarditis with giving aspirin, NSAID, cortisone, and whatever is also causing the pericardial effusion. in terms of systemic effect. Like, for example, a patient with TB now, if TB is the cause, for example, now, apart from of this, it will be important to make sure we take care of the TB. And the pericarditis is also, or cardiac surgery is indicated for cardiac tamponade or symptomatic moderate to large pericardic effusion, not responsive to medical therapy, and for suspicion of unknown bacterial or neoplastic etiology. So, just in the table, common causes of cardiac tamponade, which we talked about when we had the lecture earlier, and the uncommon ones. We're just going straight to diagnosis and treatment. In patients with clinical suspicion of cardiac tamponade, echo is recommended as first-line imaging technique, which will help us to assess the size, the location, and degree of hemodynamic impact of the pericardic effusion. And urgent pericardiocentesis or cardiac surgery is recommended to treat cardiac tamponade. And also, a judicious clinical evaluation, including echocardiographic findings, is recommended to guide the timing of pericardial sentences, basically. Okay. So for constrictive pericarditis, it can occur after pericardial disease progression, and but only rarely follows recurrent pericarditis. The risk of progression is especially related to the etiology. So for viral etiology, it's less than 1%, and for intermediate in the intermediate is 2 to 5 in immune-mediated pericarditis. However, it's said to be high in patients who have bacterial pericarditis, prevalent pericarditis. They might eventually come down with, they have higher risk of coming down with constrictive pericarditis. Okay, and I think we are familiar with the clinical features of pericarditis. It indicates diastolic filling of the ventricles, and so the classic picture is characterized by signs and symptoms of right heart failure with preserved right and left ventricular function in absence of previous or concomitant myocardial disease. But we all know that over time, because of the proximity of the pericardium to the muscle, there might be affectation of the myocardial muscles and the myocardium over time, which may also compromise the ejection fraction as the disease progresses. And other things to note, patient might complain of fatigue, peripheral edema, breathless, and sweat, abdominal swelling. Okay, so just to I think the familiar with most of them, let me just move forward to investigation for constrictive pericarditis. So transthoracic echo is also a class 1 recommendation. Chest X-ray is important with frontal and lateral views with adequate technical characteristics. Is recommended in all patients with suspected constrictive pericarditis, and the CT and CMR are indicated as the second-line imaging techniques to assess calcifications, pericardial thickening, and the degree and extension of pericardial involvement. And cardiac characterization is also indicated when non-invasive diagnostic methods do not provide definite diagnosis of constriction. Okay, so they also split them into syndromes. We have the transient constriction, and the differentials there are permanent constrictive pericarditis or restrictive cardiomyopathy. And for transient, it's defined as reversible pattern of constriction following spontaneous recovery or medical therapy. So reversible pattern of constriction following spontaneous recovery or medical therapy. And then for the therapy, a 2 to 3 months course of empiric anti-inflammatory medical therapy is advised. And then second group of syndrome considered is the effusive constrictive pericarditis, and the differentials there are cardiac tamponade constrictive pericarditis, and is defined as failure of the right atrial pressure to fall by 50% to a level below 10 millimeters of mercury after pericardiocentesis is done, and may be diagnosed also by non-invasive imaging. And the therapy pericardiocentesis is followed by medical therapy, then surgery for persistent cases. And for chronic constriction, which differentials could involve transient constriction with cardiomyopathy, persistent constriction for about 3 to 6 months, and a pericardectomy is also advised here. Medical therapy for advanced cases or high risk surgery or mixed forms with myocardial involvement. Okay, so the primary management for constriction pericarditis is the pericardectomy, and the medical therapy of specific pericarditis, for example, tuberculous pericarditis is recommended to prevent progression of the constriction, and the empirical anti-inflammatory therapy may be considered in case we transcend on new diagnosis of constriction with concomitant evidence of pericardial inflammation. Thank you for listening. His contributions and additions. Thank you.
Thank you so much, Chief Odoye, for that lucid presentation. Please, the platform is open, Chiefs, for your comments and contribution. Thank you.
Please comment, please. And contributions, please.
Thank you so much, Dr. Augustine.
I think I take the silence as no question. Maybe you can go to the next
Yeah,
guideline. Thank you.
that's what I thought too. You've convinced every one of us, and we are thankful to you. We hope that we'll be able to make use of this if it comes out in the exam. Thank you for taking us. Thank you, sir. So we'll be going to the next guideline presentation if there is no comment. Sure, Dr. Alagbe, are you ready, ma'am?
Yes, Dr. Adeojo. Good evening.
Good evening, ma'am.
Okay, let me share my slide. And not slide, please, the document, because I didn't have time to.
We are ready to work with whatever you have, ma'am. Thank you, ma'am.
Okay. Yeah, you're welcome. So I sent something to the group, a document actually. It summarizes virtually everything I'm going to say. Atrial fibrillation guideline at a glance. So I've sent it to the group. So that maybe later you guys can go through it and look at it. So good evening, everyone. I'll be speaking on guideline for atrial fibrillation. I'm more conversant with the American Heart Association guideline. So that's what I'm going to talk about. But at the end, I'm going to outline some differences with the ESC guideline. So, okay. So atrial fibrillation is the commonest type of supraventricular tachycardia. It is a form of supraventricular tachycardia that is characterized by uncoordinated atrial activation and then ineffective atrial contraction. So previously, as we know, they grouped, previously, it was grouped into 5 or classified into 5. So then the classification was paroxysmal AF. We have, first lone AF, then paroxysmal, then persistent, then long-standing persistent, then permanent. But the AHA guideline that came out last year, November, now brought out a different classification, and it classified it into 4. So that's what I'm showing now. So the first classification is the at risk for AF. So these are people that don't have AF and they don't have any structural problems, but they have cardiovascular risks. That's the modifiable and non-modifiable risks that has been associated with AF. So the modifiable risk factors, we can see the first one: obesity, lack of fitness, hypertension, sleep apnea, alcohol, diabetes. Then non-modifiable: genetics, male sex, and age. So this is the group at risk for AF. Then the second group is the pre-AF. These are people that have structural and electrical findings that can predispose them to AF, but they don't have the AF. So they have structural and electrical findings, but they don't have the AF. So what are these findings? They have atrial enlargement, they have frequent atrial ectopy, they have short burst of atrial tachycardia, they have atrial flutter, and other high AF risk scenario. Then the third group is actually the third group, or the third stage is actually the AF group. And this one has A, B, C, and D. So the 3A are the people that have paroxysmal AF. As we know, paroxysmal AF is defined as intermittent AF that terminates within 7 days, usually on its own. Then persistent AF is the 3B, is AF that is continuous and is sustained for more than 7 days and it requires intervention. While the long-standing persistent is AF that is also continuous and it lasts for 12 months, above 12 months. Then 3D are the people who are actually free from AF. Either they've undergone percutaneous intervention or surgical intervention to eliminate the AF. So maybe successful AF ablation. So that's 3D. So let's remember so that we'll not confuse it, because it's easy for you to actually bring permanent AF under 3D. So 3D are people that have been treated and they are free from AF. Then now the fourth classification is the permanent AF. These are people where the doctor and the patient have discussed about the patient's AF and they've agreed on no further attempts in achieving rhythm control. So they agreed that the patient will be on rate control. So for all the stages, you try to treat modifiable risk factor. Sorry, let me be using my cursor. So for all the stages, you try to treat the modifiable risk factors. Then for people that have pre-AF, you will treat modifiable risk factor and you have heightened surveillance. So you tell them to come in as frequent as maybe every 4 to 6 months for you to see and check whether they've developed AF. That's for stage 2. Then for stage 3, they are the people that already have the AF. So you will ask yourself, is AF associated with any pathophysiological changes? What is their AF burden like? Do they have some symptoms? If they have, you treat. Then you also check their stroke risk assessments and give therapy if appropriate. Then any symptoms they have, you treat. So that's stage 3 and stage 4. You do the same. So next is page 16. Sorry, this will, okay. So this page is actually showing the pillars of AF management. So these pillars, they are targeting the risk factors that are associated with AF. So he said that when patients have heart failure, you treat. You encourage them to exercise about 210 minutes per week of moderate to vigorous exercise. If they have arterial hypertension, you bring it down to less than 120. Diabetics, you try to control their sugar. If they are smoking, you advise them of cessation of smoking. Then obese patients, you tell them to lose at least 10 or more % of their body weight. Then if they are taking alcohol, you tell them to minimize or eliminate alcohol. Then patients, you also screen patients for sleep disordered breathing. So that's what this slide is talking about. Then, okay. So this one is about definition of some. So I've defined some of them. So I want to pick subclinical AF. Subclinical AF refers to arrhythmias identified in patients who don't have symptoms attributable to AF and in whom there are no previous ECG documenting AF. Then also, I'll pick atrial high rate episodes. So these are people that actually they have a pacemaker. So it is defined as atrial event exceeding the programmed detection rate limit set by the device. These are recorded by implanted devices, but require visual inspection to confirm AF and exclude other atrial arrhythmias, active-heart, and oversensing. So what this one means is that people that are on pacemaker, when we put pacemaker, we set it at a program rate limit. So by the time you are exceeding this, you start thinking of maybe the patient has atrial fibrillation, but you still have to look at it as a clinician. You have to visualize it and rule out other types of atrial tachycardia and make sure that this pacemaker is not oversensing maybe muscle movements, so that you will now say that the patient have AF or something like that. Then long-standing, I've defined this once. Okay. Then they said the term chronic AF is no longer used because they said that actually AF is a continuum. So they start from paroxysmal and they end with permanent. Then even valvular and non-valvular terms are no longer used. Even lone AF is no longer used. So I just want to talk about this table is actually showing us the mechanism and pathways leading to AF. So if we look up here, these are some of the pillars that they asked us to address. So for example, people that have hypertension or valvular heart disease, they tend to have increased activation of RAS. And we know with activation of RAS, there's actually increased fibroblast activity, which will lead to deposition of collagen and remodeling. So these tend to set a form of fibrosis that can lead to atrial fibrillation. Then also people that have RAS activation, angiotensin will still help in remodeling of the atrium. So it will lead to atrial hypertrophy and then lead to cardiomyopathy. And with cardiomyopathy, there is slowed atrial conduction, and slowed atrial conduction predisposes someone to having AF. Then also sleep disordered breathing. There's autonomic dysfunction, there's problem with mitochondrium, then release of reactive oxygen species, and this can also lead to that. So that's a little about that. Then going to 20. So now let's start with the guidelines. So one, they said addressing, okay, no, sorry, this is not really important. 22. So now looking at this, okay, this one is concerning basic clinical evaluation of patients that have AF. So class 1 recommendation says, in patients with newly diagnosed AF, a transthoracic echo is done to assess cardiac structure, then laboratory testing to include complete blood counts, metabolic panel. That's metabolic panel include kidney function test, fasting lipid profile, uric acid, and fasting blood sugar. Then thyroid function test. This should be done in patients that are newly diagnosed of AF to assess to assess any other medical condition that may be associated with AF. So this is a class 1 recommendation. Then they also said that in patients with newly diagnosed AF, protocolized testing for ischemia, acute coronary syndrome, pulmonary embolism should not be routinely performed to assess the etiology. So this is a class 3 recommendation. So they said we should not do routine testing for ischemia, acute coronary syndrome, or pulmonary embolism. Okay. So here is talking about, okay, so reading monitoring tools and methods. Class 1 recommendation, they said among individuals without known history of AF, it is recommended that initial AF diagnosis be made by a clinician using visual interpretation of ECG signals, regardless of the type of reading or monitoring device. So for us to newly diagnose a patient with AF, we need to see an ECG, regardless of the reading or the device that is monitoring, that is used in monitoring the patient. Then another class 1 recommendation says, in patients with intracardiac reading device capable of diagnosis of AF, such as from an atrial pacemaker, a diagnosis of AF should only be made after it is visually confirmed by reviewing the intracardiac tracing to exclude signal artifacts and other arrhythmias. So I said this earlier. So for example, now patients that have intracardiac device, they are the ones that will have that atrial high rate episodes. So when they have it, you don't just assume that they have AF or you diagnose AF. So you still have to print it out and look at the tracing. Be sure that it is not an artifact or the pacemaker is not oversensing. So this is a class 1 recommendation. Then it's also said a class 2A recommendation for patients who have had a systemic thromboembolic event without a known history of AF and in whom maximally sensitivity to detect AF is sought. An implantable cardiac monitor is reasonable. So this is saying that, for example, patients that we never knew them with history of AF, they now came down with a stroke. It is advisable that we use an implantable cardiac monitor in order to diagnose this AF. Then another class 2 recommendation is saying that among patients with a diagnosis of AF, it is reasonable to infer AF frequency, duration, and burden using automated algorithm available from the electrocardiographic monitors, implantable monitors, and cardiac reading devices with an atrial lead, recognizing that periodic review can be required to exclude other arrhythmias. So if we are diagnosing a patient with AF, we still have to check for the frequency, the duration, and the burden. So we still need to get printouts from ECG monitors or any implantable cardiac device in order to recognize that period where they had the burden and then we can monitor the frequency and also the duration. Sorry, please, this thing is cumbersome, so I have to move fast. Okay, so going to lifestyle and risk factors modification for AF management. Okay, that's part of what I said for patients at risk of AF. So there are some lifestyle and risk factors modification that we need to do. I've talked about them earlier. So they're just talking about patients at increased risk of AF should receive comprehensive guideline-directed lifestyle and risk factor modification for AF, targeting obesity. So for obese patients, it is advised that they lose 10% or more of their body weight, and they should exercise for moderate to vigorous exercise of about 210 minutes per week. So that covers for obesity and physical inactivity. Then for people with unhealthy alcohol consumption, it's advised that they cut down their alcohol consumption, or if possible, they stop alcohol consumption. Then for people smoking, they stop smoking. Diabetes, we control their glucose, achieve a good glucose control. Then hypertension also achieve good blood pressure control. So this is still it. For obesity, people greater than 27 kg, BMI of 27, more than 27 kg per meter square, they should lose 10%, at least 10% of their body weight. This will actually help in reducing AF symptoms, the recurrence and the progression. Then people should exercise for a target of 210 minutes per week. This will also improve their exercise capacity and improve their quality of life. So these ones are the
Hello, Dr. Alabi. We understand.
Okay.
Thank you.
Okay, so yeah, you're welcome. So here they're talking about caffeine consumption. So they're saying that for patients with AF, recommending caffeine abstinence to prevent AF episodes is of no benefit, although it may reduce their symptoms, but although it may reduce symptoms in patients who report caffeine triggers or worsens AF symptoms. So they're saying that they don't recommend abstinence from caffeine, even though it may reduce their symptoms. Okay. Then, okay, for treatment of hypertension in patients that have AF, so they recommend a class 1 recommendation. They recommend that patients with AF and hypertension, optimal BP control is recommended to reduce AF recurrence and AF associated cardiovascular risks. And from some randomized controlled trials that they actually did, they found out that a single elevated BP measurement actually increases the risk of stroke in patients with AF by 50%. So they advocated that BP control should be optimal in patients that have hypertension coexisting with AF. So this is a class 1 recommendation. Then concerning sleep disordered breathing, okay, they said among patients with AF, it is reasonable to screen for obstructive sleep apnea, given its high prevalence in patients with AF, although the role of treatment of sleep disordered breathing to maintain sinus rhythm is uncertain. So this is a class 2B recommendation. So they don't know whether if patients that have patients that have sleep disordered breathing and have AF, whether if you treat the AF, you take them back to sinus rhythm is going to help with the sleep disordered breathing. So it's uncertain yet. So it's a class 2B recommendation. Then class 1A recommendation, they said concerning comprehensive care. So they said patients with AF should receive comprehensive care addressing guideline-directed lifestyle and risk factor modification, AF symptoms, risks of stroke, and other associated medical conditions to reduce AF burden, progression, and consequences. This is actually a class 1 recommendation. So patients that have AF, they should have a comprehensive care addressing all their lifestyle and then modification of the risks, and then also treat their symptoms, assess for risk of stroke and any other medical condition that they may have. So now, going to prevention of thromboembolism. So according to the guideline, they actually validated some stroke risk score. They validated Chadva's score, they validated atrial score, and they validated, I think, Gaffit score. Those are the 3 scores that they validated for assessing the risks of stroke in patients with AF. So class 1 recommendation, patients with AF should be evaluated for their annual risks of thromboembolic events using validated clinical score, such as CHADVAX. So there are actually 3 that they validated, but they talked more about CHADVAX. Then that's a class 1B recommendation. Then also patients with AF should be evaluated for factors that specifically indicate a higher risk of bleeding, such as previous bleeding and use of drugs that can increase bleeding rates, in order to identify possible intervention to prevent bleeding on anticoagulation. So for this, to assess bleeding risks now, they actually validated 3 scores. So we have Hasbled score, we have hemorrhage score, and we have atrial score. But most times we use Hasbled score. So if we use Hasbled score and they are getting 3 and above, that means their bleeding risk is high. So we have to look for if some of the bleeding risks are actually modifiable, then we should try to modify it. Then class 2A recommendation, they said patients with AF at intermediate annual risks for thromboembolic events by risk score of 1 in men or 2 in women. These are the people intermediate. Sorry, I didn't talk about that. Using CHADVA's score, you can actually classify their risks into 3. People that have low risks are when men are having score of 0 and a woman is having score of 1. That's low risk using CHADVAS. Then intermediate risk is when men are having 1 and women are having 2. Then high risk is 2 and above, both in men and women. So now for this one, they are saying that, sorry, please, 1 minute. Please excuse me, I need to pick this call.
All right, ma'am.
I'm back. Hello?
Continue.
Okay. So I was talking about people that have intermediate risks. So they say people that have intermediate risks, they should have an annual risk assessment for thromboembolic events, so as to ascertain whether they will benefit from anticoagulation. Then also they said that these people that fall within the intermediate risks, actually there are some risk factors, or there are some risk factors that were not captured inside the CHADVAS score. So that if they fall within the intermediate risks, you can actually look for this other additional risk factor, and if they have it, then you can go ahead and anticoagulate them. So these additional risk factors are obesity. Once the patient's BMI is greater than 30, it is advised that their BMI is greater than 30 and they fall within the intermediate group, you go ahead and anticoagulate. Then people that have poorly controlled hypertension, also, you go ahead and anticoagulate. People that have GFR of less than 45 mils per hour, you go ahead and anticoagulate. Then also, if they have proteinuria of 150 milligram per day, you go ahead and anticoagulate. Then people that have hypertrophic cardiomyopathy, you go ahead and anticoagulate. Then people that have enlarged left atrial volume, that's once the left atrial volume is greater or equal to 73 mils, or the diameter of the left atrium is greater than 47 millimeter, you go ahead and anticoagulate. So once they fall using the CHADVAT, they are in the intermediate risks. You look for those additional risks. Look at the GFR, look at their BMI, look at their LA size or their diameter, look at whether their blood pressure is controlled or not. Then if they have any of them, they now push them towards the high risks. Then you go ahead and anticoagulate this patient. Okay. So now this one is talking about selection of oral anticoagulants. So it's advisable that you balance the risks and the benefits of anticoagulation in patients with AF. So for this one, they said class 1 recommendation in patients diagnosed with AF who have an estimated annual risk of stroke or thromboembolic event of greater than 2%. Selection of therapy to reduce the risk of stroke should be based on the risk of thromboembolism, regardless of whether the AF pattern is paroxysmal, persistent, long-standing, persistent, or permanent. That's a class 1 recommendation. So what this is trying to say is that once you've calculated your CHADVA score and they are under high risk of thromboembolism, irrespective of the pattern of AF that they have, you go ahead and anticoagulate. And if we remembered earlier, I said AF is actually a continuum. That's why they believe that patients will always start from paroxysmal and they will progress to permanent. So irrespective of any point in which you diagnose the AF, whether it's paroxysmal or persistent, once their CHADVA score falls within the high risk, you go ahead and anticoagulate them. Class 1 recommendation. Then in patients with AF at risk of stroke, re-evaluation of the need for and choice of stroke risk reduction therapy at periodic intervals is recommended to assess stroke and bleeding risks, net clinical benefits, and proper dosing. So patients that have risk of stroke and they have AF, once you it's advised that at periodic interval, you reassess them again for their stroke risks and their bleeding risks, and then you check whether they are being dosed properly. Then another thing I want to add actually is there's somewhere they stated that using the CHADVA score, once you use the CHADVA score and the patient fall within the low risk, that's men having 0, women having 1, you don't anticoagulate, but in 4 to 6 months, you reassess them again. So every 4 to 6 months, you keep reassessing them because they said there's high probability that they are going to progress to either intermediate. So when you progress to intermediate, now you can now look for additional risk factors to either anticoagulate them or you don't anticoagulate them. Then, okay. Okay. So let's talk about the antithrombotic therapy now used in them. So sorry. Okay. So here they said class 1 recommendation now, antithrombotic therapy, that's the anticoagulation in people that are at risk of having stroke. So they said class 1 recommendation for patients with AF and an estimated annual thromboembolic risk of greater than 2% per year. That is equivalent to CHADVA's score of 2 or more in men or 3 or more in women. So these are the people in the high risks. Anticoagulation is recommended to prevent stroke and systemic embolism. This is class 1 recommendation. Then in patients with AF who do not have history of moderate to severe rheumatic mitral stenosis or mechanical heart valve, and who are candidates for anticoagulation, it's advised that direct oral anticoagulants are recommended over warfarin to reduce the risk of mortality, systemic embolism, and intracranial hemorrhage. So patients that have AF, you want to know whether they have a mechanical valve or they have moderate to severe mitral stenosis. If they don't have, then the drugs are preferred over warfarin. But if they have, actually, warfarin is preferred. So people that have mitral stenosis and mechanical heart valve, warfarin is preferred. Then 2A, so that's a class 1. Then for class 2A now, they said for patients with AF and an estimated annual thromboembolic risk of greater than 1%, but less than 2% per year, this is equivalent to 1 in men and 2 in women. So these are the people that have intermediate risks of stroke. Anticoagulation is reasonable to prevent stroke and systemic embolism. So these are people that fall within the intermediate group. So these are the ones that they also advise. So it's you actually have to make, it's like they are leaving the clinician to make the decision whether you want to anticoagulate, but they said it's reasonable. So if you want to support your fact of anticoagulating them, look for other additional risk factors that are not in the CHADVACs, and then go ahead and anticoagulate them. Then they also talked about in patients with AF who are not candidates for anticoagulation and they don't have any indication for antiplatelet, aspirin alone or in combination with clopidogrel as an alternative to anticoagulation is not recommended. So if we calculate the patient's CHADVAC score and their low risk, we should not use antiplatelets as an alternative to prevent or to reduce stroke risks in them. Also, they said this is actually class 3 and is harm. Then also class 3 that shows no benefit in patients with AF without risk factors for stroke. Aspirin monotherapy for prevention of thromboembolic events is of no benefit. So a lot of us are guilty of this at times in clinic. So patients that have AF and they don't have any risk of stroke, they're giving them aspirin. They have AF and they are low risk. Giving them aspirin to prevent thromboembolic events is of no benefit in them. So this table here by the right is just showing those additional factors I talked about earlier that are not included in the CHADVAC score. So we can see obesity, hypertrophic cardiomyopathy, EGFR of less than 45, and large LA volume and diameter. Okay, I can still use this table just to summarize what I talked about anticoagulation. So they said here, people that have stroke and systemic embolism event risk threshold for anticoagulation. So if it's greater than 2, okay, thank you. If they have if their CHADVAC score is greater than 2, so you anticoagulate them. Then if their CHADVAC score is intermediate, you may or is reasonable to anticoagulate them. So you can look for additional factors to decide on anticoagulation. Then anticoagulant of choice, class 1 recommendation, they said the drugs are preferred over warfarin, except in patients that have mitral stenosis and mechanical heart valves. Then class 3 recommendation, do not use aspirin with or without clopidogrel to reduce stroke risks is a harm. Then class 2, this is class 3 with no benefits. So if no risk for stroke, aspirin should not be used to prevent thromboembolic events. Okay. Okay. So this one is talking about consideration in managing anticoagulants. So class 1 recommendation For patients with atrial fibrillation receiving DWACs, optimal management of drug interaction is recommended for those receiving concomitant therapy with interacting drugs, especially cytochrome 3A4 and or P-glycoprotein inhibitors or inducers. That's class 1 recommendation. So if you're giving a patient DWACs, you also need to watch out for the drugs that will be administered together with this the DWACs. So they gave an example here. Actually, they said, for example, if a patient will be on ketoconazole and ritonavir, you should not give rivaroxaban, because if you give it, the ketoconazole and ritonavir, they will increase rivaroxaban plasma level, so thereby leading to toxicity. So they will be at increased risk of bleeding. Then if you must give any anticoagulants in patients receiving these drugs, that's ketoconazole or ritonavir, you can actually give apixaban. But instead of giving the normal dose of 5 milligrams twice daily, you will reduce it to 2.5 twice daily. You can also give dabigatran, but instead of giving 150 milligrams twice daily, you reduce it to 75 milligrams twice daily. So it's a class 1 recommendation. So once you're giving drugs that will drugs that interact with once you're giving them drugs that have effect on cytochrome 3A4, you have to reduce the dose of the drugs, and the ones you will use is apixaban and dabigatran. You don't use rivaroxaban in them. So this is a class 1 recommendation. Then another class 1 recommendation is that for patients with AF receiving warfarin, a target of 2 to 3 is recommended, as well as optimal management of drug-to-drug interaction, consistency in vitamin K dietary intake, and monitoring of INR is recommended in this patient in order to prevent major bleeding. So it's also a class 1 recommendation. Okay. This table is talking about oral anticoagulation for device-detected atrial high rate episodes among patients without previous diagnosis of AF. So these are patients that are on pacemaker and they've never been diagnosed of having AF. So now, using the atrial high rate episodes. So if okay, let me just read it. For patients with device detected atrial high rate episodes lasting greater than 24 hours and with Chadva score of 2 or more or equivalent stroke rates, it is reasonable to initiate oral anticoagulation. So in these patients, is a class 2 recommendation. Once the device can detect atrial high rate episode lasting for 24 hours, and then you now calculate their Chadva score is 2 or more, then it's reasonable that you anticoagulate them. That's class 2A. Then for people that the device will detect the atrial high rate episode, if it's lasting between 5 minutes and 24 hours, so it's no more than 24 hours, between 5 minutes and 24 hours, and their Chadva score is 3 or more, it is also reasonable to anticoagulate them. However, this is 2B. So if their atrial high rate episode is greater than 24 hours and they have Chadva score of 2, it is reasonable to anticoagulate them, is a 2A. But if it's between 5 minutes and 24 hours, and now their Chadva score, they took it up with 1 point, greater than 3 or greater than 3, then it's also reasonable to anticoagulate them. But if the atrial high rate episode is less than 5 minutes, it is unreasonable to anticoagulate them. So it's class 3 recommendation. So don't anticoagulate them. Okay. Then using percutaneous approaches to occlude left atrial appendage, there's no class 1 recommendation for this also. But class 2 recommendation reads, in patients with AF, a moderate to high risk of stroke, that's Chadras of 2 or more, and a contraindication to long-term oral anticoagulation due to non-reversible cause, percutaneous left atrial appendage occlusion is reasonable. So what this means is that patients that have AF, you calculate their Chadras score is greater than 2, is 2 or greater than 2, and they now have contraindication to long-term anticoagulation. So maybe they have some form of cancers, or they have some things that we cannot reverse. Maybe they have a bleeding diathesis that we cannot correct. Then it's advisable that these patients just go and occlude the left atrial appendage. Is better, because they are still at risk of having stroke, but they cannot have anticoagulants. So it's better you go and do occlusion, percutaneous occlusion of their left atrial appendage. So this is a class 2A recommendation. Then the class 2B recommendation is that in patients with AF and a moderate to high risk of stroke and a high risk of major bleeding on oral anticoagulants, it's also advisable that you do percutaneous, or is reasonable that you do percutaneous left atrial appendage occlusion as an alternative to oral anticoagulation. So based on the patient's preference, and then you also look at the risks of the procedure in the patient before you go ahead. So you try to weigh the risks of the procedure and the benefits. So if patient is having AF and they have moderate to high risk of stroke using the Chadras score, and then they are also at risk of bleeding, that's using the has bled, then you can also use this percutaneous left atrial appendage closure as an alternative, since their bleeding risk is high. So it's a class 2B. So for percutaneous occlusion of the left atrial appendage, there is no class 1 recommendation. They are class 2 recommendation. Just like the atrial high rate episode, there's also no class 1 recommendation for that. So going to cardiac, that's left atrial appendage exclusion or excision now. So they said that for patients, okay, let me read it first. So class 1 recommendation, in patients with AF undergoing cardiac surgery with a Chadras score of 2 or more, surgical left atrial appendage exclusion in addition to continued anticoagulation is indicated to reduce the risk of stroke and systemic thromboembolism. This is a class 1A recommendation. So what is trying to say here is that patients that have AF and they have high risk of stroke, and then they are going in for a cardiac surgery, so they are going in for another cardiac surgery, it's also advisable that you can actually go in and then remove their left atrial appendage, so that they will not have where the clots can form, or where they will have a thrombus. So it's not that you will just go in and then or you just fix surgery just to go and remove the left atrial appendage. You must have an indication for another cardiac surgery. So you just go in, do your cardiac surgery, then also surgically excise the left atrial appendage. Is a class 1 recommendation. Another class 1 recommendation here is that in patients with AF undergoing cardiac surgery and LA, that's left atrial appendage exclusion, is surgical technique resulting in absence of flow across the suture line and a stump of less than 1 centimeters, as determined by intraoperative transesophageal echo, should be used. So what it's trying to say is that once you want to go and do this surgery, that's they are going for cardiac surgery, and you also want to excise the left atrial appendage. So try as much as possible so that there will not be flow of blood across the suture line, and the stump that you are leaving behind should be less than 1 centimeter. So you use esophageal echo to determine this intra-op. I think enough about this one. Okay. Okay. So active bleeding on anticoagulant therapy. So the anticoagulants that are used here, sorry, I forgot to say that, but the drugs that are used in AF, you can use rivaroxaban, 20 milligrams daily. You can use apixaban, 5 milligrams twice daily. You can use dabigatran. Dabigatran is 150 milligrams BD. Then you can use endoxaban, 60 milligram. Is it 60? Yes, 60 milligrams daily. So now they're talking about if there's active bleeding while the patient is on these anticoagulants, what are the means of reversing the bleeding? So class 1 recommendation. In patients with AF receiving dabigatran who develop life-threatening bleeding, treatment with indaruzumab is recommended to rapidly reverse dabigatran anticoagulation effects. This is a class 1. So for patients on dabigatran, you use indaruzumab to reverse it, class 1 recommendation. Then I'm going to 3 first, please. In patients with AF receiving factor 10, activated factor 10 inhibitors who develop life-threatening bleeding, treatment with either andexanate alpha or 4-factor prothrombin complex concentrate is recommended to reverse the anticoagulant effect. So for patients who are receiving activated factor 10 inhibitors, that's apixaban, rivaroxaban, and endoxaban, to reverse the bleeding, we can either use andexanate alpha or we use 4-factor prothrombin complex concentrates. These two are class 1. Then class 2, also, this one is with respect to dabigatran. He said in patients with AF receiving dabigatran who develop life-threatening bleeding, treatment with activated prothrombin complex concentrate is reasonable if indaruzumab is unavailable. So if patient is taking dabigatran, they develop bleeding, class 1A, use indaruzumab. If there is no indaruzumab, class 2A, use activated prothrombin complex concentrate. Okay, another class 1A, now talking about warfarin. So they said in patients with AF receiving warfarin who develop life-threatening bleeding, treatment with 4-factor prothrombin complex concentrate, if available, in addition to IV vitamin K is recommended over fresh frozen plasma with IV vitamin K. So here they're saying that patient is having AF, patient is receiving warfarin, patient started having life-threatening bleeding. It's advisable you use both IV vitamin K and 4-factor prothrombin complex concentrates. So it's better than using fresh frozen plasma and IV vitamin K. Okay. Now, management of patients with AF and intracranial hemorrhage. There is no class 1 recommendation for this one, but the class 2A recommendation is that in patients with AF and conditions associated with high rates of thromboembolic events greater than 5% per year, such as rheumatic heart disease or they have a mechanical heart valve, early resumption of anticoagulant after intracranial hemorrhage is reasonable to reduce the risk of thromboembolic events. So what it means is that patients have AF, they now have high risks of thromboembolic events, such as maybe they have a mechanical valve in situ or they have a rheumatic heart disease like mitral stenosis. It is advisable that following an intracranial hemorrhage, it is advisable that you recommence the anticoagulants early. That's maybe 1 or 2 weeks after the hemorrhage to prevent further risks of thromboembolic events. Then that's class 2A. Then the class 2B is that patients with AF and intracranial hemorrhage, it's advised that you can actually delay resumption of anticoagulants when you weigh the benefit of either a thromboembolic event or a hemorrhagic complication. So you have to wait. After weighing it, then you can decide to start within 4 to 8 weeks. Then that's a class 2B recommendation. Then another class 2B recommendation is that in patients with AF and conditions associated with high rates of recurrent intracranial bleed, like people that have amyloid angiopathy, anticoagulation sparing therapy such as percutaneous left atrial appendage occlusion may be considered to reduce the risk of recurrent hemorrhage. So this is a class 2B. Patients who have AF and they have high risks of intracranial bleed, people that have amyloid angiopathy. So you can actually consider sparing them of anticoagulants and then consider a percutaneous occlusion of the left atrial appendage is a class 2B. Okay, this table just summarized what I said earlier. I don't know whether I should explain it again. Okay, let me just explain it again. So people who have active bleeding associated with oral anticoagulants. So if it's a minor bleed, you carry out some supportive measures, then you withhold the anticoagulants until hemostasis is achieved. Then if they have life-threatening bleeding now, for dabigatran, reverse with idaruzimab. That's class 1. Then class 2, activated prothrombin complex concentrates if idaruzimab is not available. Then for patients on activated factor 10 inhibitors, you can use andexanate alpha. For that's rivaroxaban, apixaban, and endoxaban. Or you can use 4-factor prothrombin complex concentrates. Then for patients with warfarin, you can use 4-factor prothrombin complex concentrates together with intravenous vitamin K. So that's what I said earlier. Okay, pre-procedural management. Okay, this one I'll just talk about some. So for people that pre-procedural, okay, these are people that want to go for invasive procedure and they have AF and they are on anticoagulants. What should you do? So class 1 recommendation in patients with AF, excluding those with recent stroke, TIA, or mechanical valve. So in patients with AF and on oral anticoagulation, either warfarin or DUAC, who are scheduled to undergo an invasive procedure or surgery, temporary cessation of oral anticoagulation without bridging anticoagulation is recommended. So these are patients that have AF and they are on oral anticoagulants. They want to go in for an invasive surgery. It's advised that you can actually temporarily stop their oral anticoagulation and don't give them any bridging anticoagulation like low molecular weight warfarin in order to go for the surgery. So you can actually temporarily cease the oral anticoagulation without giving them any bridging therapy. Then another class 1A is that in patients with AF on DUAC and scheduled to undergo an invasive procedure surgery that cannot be performed safely on uninterrupted anticoagulation, the timing of interruption of the DUAC should be guided by the specific agent, renal function, and the bleeding risks of the procedure. So if the patient is going for an invasive procedure and they are on direct acting oral anticoagulants, is not advisable to stop the anticoagulants, then you have to look at the individual drug you're using, and then look at the renal function of the patients, and then the bleeding risks of the procedure also. So for example, if patient's renal function is depressed, you know that maybe they will not excrete the drug early. So maybe the plasma concentration of the direct acting oral anticoagulants will still be high. So you can actually just allow them for some time. Okay, then this one is talking about anticoagulation in specific populations. Sorry, we'll soon be done. Anticoagulation in specific population. So this is about AF and acute coronary syndrome, or PCI. I remember asking it one time, was it last week Sunday when Dr. Sarah was presenting? So class 1 recommendation, they said in patients with AF and an increased risk of stroke who undergo PCI, direct oral anticoagulants are preferred over vitamin K antagonists in combination with antiplatelets to reduce the risk of clinically evident bleeding. So what he's saying is that if patient is having stroke, if patient is having AF, and their CHA2DS2-VASc score is high, and they are to undergo PCI or they've undergone PCI, it's better we use direct oral anticoagulants like rivaroxaban over warfarin. Then we now add it with one antiplatelet, actually. That's the second point. So we use it together with one antiplatelet. So the second point now is, in most patients with AF who take oral anticoagulation and undergo PCI, early discontinuation of aspirin 1 to 4 weeks and continuation of dual antithrombotic therapy, oral anticoagulants, and P2Y12 inhibitor is preferred over triple therapy. So in these patients, patient has AF and they have high risk of stroke, so they need to take oral anticoagulation. So what is advised is that you give them the triple therapy that they normally give after PCI. So aspirin and maybe ticagrelor or clopidogrel or pasugrel. But now 1 to 4 weeks after the procedure, you stop the aspirin, because we know that aspirin is it's irreversible. So you stop the aspirin and it has higher bleeding risks. So we stop the aspirin, then we now continue one, that's either the rivaroxaban or apixaban together with a P2Y12 inhibitor. So it's preferred over continuation of the triple therapy. So they said in patients with chronic coronary disease, class 1 recommendation, patients that have AF with chronic coronary disease, that's coronary disease beyond 1 year after revascularization, or coronary artery disease not requiring coronary revascularization, without history of stent thrombosis, oral anticoagulation monotherapy is recommended over combination therapy to decrease the risk of major bleeding. So just one oral anticoagulant is recommended without any antiplatelets. So we can just give maybe rivaroxaban and they continue. So that's in patients with chronic coronary disease, that's greater than 1 year. You just give them only monotherapy of oral anticoagulant, and rivaroxaban is actually the preferred choice. Then class 2B indication, this one is for peripheral arterial disease. So they recommend that in patients with AF and concomitant stable peripheral arterial disease, monotherapy oral anticoagulation is reasonable over dual therapy, that's anticoagulants and antiplatelets, to reduce risk of bleeding. So people that have AF and they have stable peripheral artery disease, anticoagulation alone is preferred over anticoagulation and antiplatelet therapy. This is a class 2E. Okay. So this one is for patients that have CKD. So for patients with atrial fibrillation at elevated risk of stroke and they have stage 3 CKD, treatments with warfarin or preferably evidence-based doses of direct thrombin or factor 10 inhibitor is recommended to reduce the risk of stroke. So these are the patients that if they have CKD and they have AF and they have increased risk of stroke, you can actually reduce the dose of the direct acting oral anticoagulants. And they said in patients that have CKD, it's actually advisable you use apixaban. It's more renal friendly. Yes, so you can reduce the apixaban dose to 2.5 milligrams twice a day. Okay. Then here is talking about, I think I've said this before, AF in valvular heart disease, you use warfarin. Or people that have mechanical heart valves. Okay, here actually, they are talking about typical atrial flutter. I don't think, but it's almost the same treatment with AF. Okay, so here we want to talk about rate control. The drugs we can actually use in rate control. Let me just scroll down. Okay. For rate control, sorry, please, I'm coming. Rate control, page 62. Please, hope you guys can hear me. Hello?
Sure, you're audible, ma.
Okay, sir. Okay, thank you. So let me just, okay, please, I want to use this table to talk about the rate control, acute rate control in AF with rapid ventricular response. So if a patient has AF and they have rapid ventricular response, so you will want to do rate control. Most times you look at whether the patient is hemodynamically stable or unstable. Then if the patient is even hemodynamically stable, you also want to look whether it's the younger age group or the older age group. So in the older age group, most times we prefer rate control. So you check whether they are hemodynamically stable. If they are not, you do direct current cardioversion. So you use electric current of about 200 joules to cardiovert, and you make sure you give a synchronized direct current cardioversion. Then if they are hemodynamically stable, but they now have decompensated heart failure, so they advise that if they have decompensated heart failure, class 2B recommendation is that you use amiodarone. Do not use the non-dihydropyridines, that's the verapamil and diphtiazine. They actually cause more harm in these patients. We know that calcium channel blockers, especially those ones that have both chronotropic effects and inotropic effects, they can actually worsen it in heart failure. So you don't want to use diphtiazine and verapamil. So for patients that don't have decompensated heart failure, so they have AF and then they don't have decompensated heart failure. Class 1 recommendation, you can use beta blockers. You can use verapamil, diphtiazine. That's class 1 recommendation. If that doesn't work, you can add digoxin to it. Then if still that doesn't work, so adding of digoxin is class 2A. Then if still that doesn't work, you can add amiodarone. That's 2B. So here, just know that usage of amiodarone in acute rate control of AF is a class 2B recommendation. Digoxin is 2A. Beta blockers is 1A if there's no decompensation. Beta blocker is 1A if there's no decompensated heart failure. Then they said for long term, that's after the acute rate control. For long-term control, class 1, beta blockers and non-dihydropyridine calcium channel blockers are recommended for long-term control with choice of agent according to the underlying substrate and comorbid condition of the patient. So you still look, if they have heart failure, you don't want to give them diltiazem and verapamil for long-term control. Then they add class 2B, class 2A recommendation. They said if you're giving the patient warfarin, make sure that, digoxin. If you're giving the patient digoxin, make sure that the digoxin target level is less than 1.2 nanogram per ml. So this is just what I explained. So here, long-term rate control. Do they have depressed ejection fraction? That's less than 40. If it's yes, you can give them beta blocker. You can give them digoxin. Then if the ejection fraction is greater than 40, you can give them beta blocker, diltiazem and verapamil. And then class 2, you can add digoxin. But class 3 recommendation, do not give diltiazem and verapamil in people that their ejection fraction is less than 40. Okay, AV nodal ablation. For class 1A recommendation, these are people that they recommend that people that have AF, we expect that with increasing atrial electrical activity, the AV node should be able to slow down what is being conducted to the ventricle. But when this does not happen, so patient is having AF and they're having rapid ventricular response, is a class 1 recommendation that these patients should have AV nodal ablation. And if with the AV nodal ablation, they are still firing at a very high rate, then you can actually put a pacemaker and program it to be within 80 to 90 beats per minute to reduce their risk of sudden death. So patients with AF, or in patients with AF and persistently rapid ventricular response who undergone AV nodal ablation, initial pacemaker lowering rates programming should be between 80 to 90 to reduce risks. Then another class 1 recommendation in patients with AF who are planned to undergo AV nodal ablation, implantation of pacemaker before the ablation is recommended to ensure adequacy of pacing leads before performing the ablation. So if the patient is about to go for AV nodal ablation, you can actually do a pre-procedural implantation of the pacemaker. It's going to help them to see whether they adequately performed the ablation. So it's also a class 1 recommendation. Okay, so for reading control, class 1 recommendation in patients with reduced ejection fraction, in patients with reduced LV function, and persistent AF, a trial of reading control should be recommended to evaluate whether AF is contributing to the reduced LV function. So this is trying to say that if patient is having AF, persistent AF, and they now have reduced LV function, early control, early reading control should be is recommended, so that you will know whether this AF is actually contributing to the reduced LV function. This is a class 1 recommendation. So previously, this point in the previous AHA guideline, I think that's 2019, it was actually a class 2B recommendation. So they upgraded it to a class 1 recommendation. So they advise that early reading control should be done in people that have reduced LV function, because that may just be what is causing, the AF may just be what is causing their reduced LV function. Then class 2A, in patients with symptomatic AF, reading control can be useful to control to improve the symptoms. And also in patients with recent diagnosis of AF less than 1 year, reading control can be useful to reduce hospitalization, stroke, and mortality. So this table, let me just say something little about the table. So this table just they have variables that actually would different variables, and then it will tell us which one is favoring rate control, which one is favoring reading control. So patient's choice is number 1. So patient's choice, if the patient prefers rate control, give the patient rate control. If the patient prefers reading control, give the patient. Patient's age, older age group, do rate control. Younger age group, do reading control. Antecedent history of AF, longer history of AF, do rate. Shorter history of AF, try to do cardioversion. Then symptom burden, fewer symptoms, do rate control. More symptoms, do reading control. Then rate control in AF is easily controlled. Rate control in AF, easily controlled heart rates. So if you can easily control the heart rates, then rate control is better. But if it's difficult to control the heart rates, go for reading control. LA size, larger LA size, do rate control. Smaller LA size, do cardioversion. The reason for this is that with larger LA size, actually electrical remodeling has taken place already. So there's little you can do about it. So it's advised that just do rate control. Just make sure that their ventricular response rate is low, so that they will not have thromboembolism and other hemodynamic instability. But if the size of the LA is still small, you can actually do cardioversion, so that you prevent tachyarrhythmias induced cardiomyopathy, which will now lead to the electrical remodeling, fibrosis, and then they will now develop permanent AF. I think that's all for this, please. Please hope I'm not boring you guys. So the guideline is so bulky. I don't even know which one to pick and which one to leave.
Well done, ma. It's becoming long, however, for me. But thank you.
Sorry, please. I'll try and round up.
No, thank you. It's a lot of work.
I'm telling you, I didn't know which one to leave.
AF is an everyday thing, so we should get as much as we can get, Charlie.
Okay, thank you for encouraging me. Okay, so
she's going through a lot.
Okay, let me talk about. Okay, so recommendation for prevention of thromboembolism in the setting of cardioversion. So, in patients with AF undergoing cardioversion, therapeutic anticoagulation should be established before cardioversion and continued at least 4 weeks after without interruption to prevent thromboembolism. So these are patients that you want to achieve reading control. So you want them to have a cardioversion done. And these are usually patients that, for example, if it's an elective cardioversion, yes, that's the word I'm to use. If it's an elective cardioversion, it's advisable that they actually have anticoagulation for, I think, about 3 weeks. Then you do elective cardioversion, then they continue anticoagulation again for at least 4 weeks after the cardioversion. Class 1 recommendation. Then in patients with AF in whom cardioversion is deferred due to early thrombus detected on pre-cardioversion imaging, therapeutic anticoagulation should be instituted for at least 3 to 6 weeks, after which imaging should be repeated before you do cardioversion. So you want to do cardioversion again, you do a esophageal echo to see a thrombus in the left atrial appendage. So you stop the cardioversion, you give anticoagulants for 3 to 6 weeks, then you now look back using the transesophageal echo before you cardiovert. So class 1 recommendation. Please let me just talk about all the class 1 recommendations so that we can leave here. Then prevention of thromboembolism in the setting of cardioversion. Another class 1 recommendation, they said in patients with AF with duration greater than 48 hours, 3-week duration of uninterrupted. Okay, I've said this before. So for electrocardioversion, in patients with hemodynamic instability attributable to AF, immediate electrocardioversion should be performed to restore sinus rhythm. Now, these are people that have AF and it's less than 48 hours and they are hemodynamic. Okay, no, people that have AF and they are hemodynamically unstable, you do an immediate cardioversion. Normally, they say you just give, I think you give IV heparin and then you cardiovert quickly. This is a class 1 recommendation. Then in patients with AF who are hemodynamically stable, electric cardioversion can be performed as initial rhythm control strategy or after unsuccessful pharmacological cardioversion. So patients that are hemodynamically stable and they have AF, you can actually plan for elective cardioversion after an unsuccessful pharmacological cardioversion. Then also another class 1 recommendation in patients with AF undergoing electrical cardioversion, energy delivery should be confirmed to be synchronized to the QRS to reduce risks of inducing VT. I've said this earlier, is a class 1 recommendation. So if you want to shock the patient, make sure you are delivering a synchronized DC to avoid VT. These ones are class 2 recommendation. Okay, I think there's the diagram now. Okay. Now, for atrial fibrillation, now, if you want to do pharmacological cardioversion, there's no class 1A recommendation for pharmacological cardioversion. There are 2A and 2B. So you look, patient is having AF, the LV function is normal. You can use amiodarone, IV amiodarone, you can use IV ibutylide, class 2A. Then class 2B, you can use procainamide, where if the class 2A amiodarone and ibutylide are not tolerated or they are contraindicated, so you can use procainamide. Then for patients that have HFrEF with ejection fraction of less than 40, class 2A, you use IV amiodarone. Then for patients that have AF outside the hospital, they advise that they can actually have pill in the pockets, and the pill in the pocket that they should take should be flecainide or propafenol. So I think these first two, AF, check the ejection fraction. It is normal, amiodarone ibutylide 2A, procainamide 2B. If the ejection fraction is reduced, only amiodarone. Okay. Almost there. Let me go to 84, catheter ablation. This is another, they upgraded it from a 2A to a class 1. Yes, let me talk about this. Okay. In the 2019, and even the ESC guideline of 2020, this part that I want to talk about now is actually 2A. So AHA have upgraded it last year to a class 1. So class 1, they said in patients with symptomatic AF in whom antiarrhythmic drugs have been ineffective or contraindicated or not tolerated or not preferred, and continued rhythm control is desired, catheter ablation is useful to improve symptoms. This is now a class 1E recommendation. Also, in selected patients, younger age group with fewer comorbidities, with symptomatic paroxysmal AF, in whom rhythm control is desired, catheter ablation is useful as first-line therapy. This will reduce their symptoms and it will reduce progression to persistent AF. This is also class 1. Then also in patients with symptomatic or clinically significant atrial flutter, catheter ablation is also useful to improve symptoms. So these first two I read, that's catheter ablation in people that cannot tolerate antiarrhythmic drugs or is not effective for them. They upgraded it from a 2A to 1A. And also in younger patients who have symptomatic AF, you want to prevent it from progressing to permanent, persistent. So they upgraded it, so they should have catheter ablation as first line. So they upgraded it to class 1A. Then they also said patients that 87 patients that are having recurrent AF, they also advised 86. Okay. Then also they said in patients undergoing ablation for AF, PVI means pulmonary vein isolation is recommended as the primary lesion set for all patients. So this is a class 1A. So if we want to go in and do ablation, catheter ablation, the primary target should be the pulmonary vein focus for the ablation, is a class 1A recommendation. Then other sites can be class 2. Then here they say patients that are having recurrent AF after catheter ablation, class 1A recommendation, you can actually repeat another catheter ablation, or you can give them antiarrhythmic drugs to improve their symptoms. So if they've had catheter ablation before and they are still having recurrent symptoms, you can go ahead and repeat the catheter ablation. Let me jump to 99. Pre-excited AF. 99. Okay. Okay. So people that are having Wolff-Parkinson-White syndrome and other pre-excitation syndrome, and they're having AF. So they have 3 class 1 recommendation here. It said patients with AF and rapid anterograde conduction, that's pre-excited AF, and hemodynamically unstable should be treated with electrical cardioversion. So pre-excited AF, hemodynamically unstable, electrical cardioversion. Then if they have pre-excited AF, they can also have catheter ablation of the accessory pathway. This is also a class 1B recommendation. Then if they have pre-excited AF and they are hemodynamically stable, they can have pharmacological cardioversion. So using either intravenous ibutylite or intravenous prokinamide as an alternative to electrical cardioversion. So these 3 are class 1A. So pre-excited AF, unstable cardioversion, pre-excited AF, they can have catheter ablation of the accessory pathway. Pre-excited AF, hemodynamically stable, pharmacological cardioversion using ibutylide or prokinamide recommended. Okay, please. Please, I'm almost done. I'm looking for, I didn't write the page. Okay, please, I can't find this one, but let me just say it. They said people that have AF and they have HOCM, it is a class 1 recommendation that even without calculating their CHADVA score, just go ahead and anticoagulate them, because it's already assumed that for someone that is having HOCM and having AF, their CHADVA score is 3 and above. So you anticoagulate them. So that's for hypertrophic cardiomyopathy and AF. So just go ahead and anticoagulate them. It's assumed that their CHADVA score is 3 and above. Then lastly, page 104. Okay, I think I'm there. That's patients that have AF in acute illness. Okay, yes, patients that have AF in acute illness or after surgery. As we know, sepsis is actually a cause of AF, because they said it causes some form of inflammation, and that can perturb the electrical conduction also. So it can also make a patient to have a form of paroxysmal AF while they are sick, but most times it tends to resolve after their illness. So class 1 recommendation, patients with AF who are identified in the setting of acute medical illness or surgery should be counseled about the significant risks of recurrent AF after the acute illness has resolved. So once they have AF in acute illness, you should counsel them that even though with this illness, the AF may resolve, but they are prone to having another one. Then class 2A, in patients with AF who are identified in the setting of acute medical illness or surgery, outpatient follow-up for thromboembolic risk stratification and decision-making on oral anticoagulant initiation or continuation, as well as AF surveillance, can be beneficial given a high risk of AF recurrence. So he's just trying to say that patients that had AF after a surgery or during an acute illness, is good you arrange a follow-up visit for them, so that you can either decide whether they may need oral anticoagulation, and then you keep them on surveillance for AF. I think that will be all. Okay, please, sorry, I still have to go to another slide. Sorry, I'm coming, please. I just want to see something from the other one. The one I sent to the group. That's AF at a glance. So maybe we can just go through it later. This table is showing us, is comparing the previous AHA guideline of 2019 with 2023. So 2019 also classified AF according to paroxysmal persistence, long-term persistence, and so now they've changed it to at risk, pre-AF, AF, and then permanent AF. Then in 2019 also early reading control was actually a 2B recommendation, in which they advised that heart rate control strategy is reasonable for symptomatic management of AF. So they brought it to class 1A, that's patients that have reduced left ventricular function and have persistent AF should actually have an early rhythm control. So it's now a class 1 recommendation. Then catheter ablation, I said it earlier, it was formerly a class 2A recommendation. Now they brought it to a class 1 recommendation. Then when comparing it with ESC, okay, so they compared this current one with ESC. ESC is still maintaining the 5AF pattern. This was their last guideline was 2020, so they are still maintaining the 5 pattern, while the AHA now has the 4 stages. Then early rhythm control in ESC, they said early rhythm control therapy is recommended for symptom and quality of life improvement in symptomatic AF. That's a class 1 recommendation. So in AHA2, class 1. Then catheter ablation, I said it earlier, I said it's a class 2A recommendation, while AHA brought it to class 1. So I think that's all. If we go through it again, we'll have a better idea. Thank you.
Chief Alagbe,
Yeah.
we sincerely appreciate it. This is a lot of work. Thank you so much, ma'am. Very, very grateful. Please, Chiefs, the platform is open for contributions and comments.
But do you guys still need summary of all what I said?
Well,
I don't know.
Well,
just to highlight points.
a recap will actually be good. A recap will be
okay.
good.
Okay.
If
One.
it's not hope it's not so much asking you for too much, ma.
No.
Thank you, ma.
So 1.
Sorry, Dr. Halagbe. Sorry, because of
Yes.
before your recap, thank you so much for the presentation. I'm not sure if I missed it, although I tried to listen keenly. I was distracted a little. Did they talk about those in AF with thrombus in the chambers? Is there anything on the guideline on that?
Okay. Yes, Dr. Orimodade. Yes.
Yes. Okay.
He said people that have AF and they have thrombus, you first go and do a TEE. If you see a thrombus there, you're going to defer your cardioversion. So you go ahead and anticoagulate them for like 4 to 6 weeks. Then you go back and look for the thrombus.
Yes, sorry,
okay.
Not in respect to that, in respect to the type of anticoagulation that is preferred in them. Is it NOACs? Is it warfarin?
Okay.
If it's non-valvular.
No, if it's non-valvular, it's DUAX.
It's DUAX.
It's only
with thrombus.
Yes.
Okay. I just need a clarification.
It's only in mitral stenosis and mechanical heart valves that he said, yes, warfarin is preferred.
In the new guidelines. Okay. Thank you. Thank you. Claire. Thank you. Over. Thanks so much.
Okay, so I said in summary, AF is now staged into 4, where we have the at risk. Those are people that have risk factors, modifiable and non-modifiable risk factors for AF, but they don't have AF. Then pre-AF are people that have structural and electrical changes that can predispose to AF, but they don't still have symptoms of, they don't have AF. Then stage 3 are people that have AF, paroxysmal, persistent, long-standing, and permanent, and people that have had successful ablation. Then stage 4 is people that have permanent AF, that they don't even want to achieve rhythm control again. Then I also talked about the pillars of lifestyle modification, where all of them are actually class 1 recommendation. People that are obese should lose weight, at least 10%. BP should be controlled optimally. They suggested 120 of systolic. Then tight glycemic control. They should have physical activity of 210 minutes per week. And then people that take alcohol should cut down or they should eliminate. Then smoking, they should stop. So that's that. Then I went ahead and I talked about use of catheter ablation, which was formerly a class 2A recommendation, but is now a class 1 recommendation. And they talked about younger patients that have paroxysmal AF, that it's advisable that they can actually benefit from catheter ablation as first-line therapy in order to improve their symptoms. So, and then they also talked about people that are on people that are on anti-arrhythmic therapy, but maybe the drug is ineffective or they can no longer tolerate it, or due to some contraindication or even patient's choice. You can actually do a catheter ablation for these people. They'll benefit from it. It's also a class 1 recommendation. Then even people that have symptomatic heart failure with AF, they can also benefit from catheter ablation. And it's also advised that when you want to catheter ablate, the first primary site that you should go and ablate is actually the pulmonary vein focus before you survey for others. Then I talked about rate control and rhythm control. I said people that have ejection fraction less than 40, you won't want to use the non-dihydropyridines like diltiazem and verapamil. So you go for beta blocker class 1. Then you can also add digoxin class 2. Then people that have normal ventricular function, you can actually use beta blocker non-dihydropyridine. Then what else? Then I talked about people that have acute illness. They can actually have AF. So you have to advise them or cancel them on recurrent AF, class 1 recommendation. Then you can also arrange follow-up visits for them for surveillance in case they develop another AF or their risks for thromboembolic event increases. So you may want to consider oral anticoagulants. Then what else? Okay, I think that's the ones I can remember. Thank you.
Dr. Alagbe, once again, thank you so much for all your efforts and an excellent presentation. Chiefs, the platform is open for contributions and comments. Chief Alagbe, sorry, let me start off. I would like to ask, you mentioned that aspirin or clopidogrel or aspirin alone, there's one in the arm group and then there is one that is of no benefit. Did you by chance come across studies that back those points up? Thank you.
Okay, Dr. Adeyemi, I actually saw them, but I can't remember.
Okay.
There are actually studies that backed them up,
Okay.
but I can't even remember the study, and they've taken my lights. So I actually jotted down some studies, some things, but now I can't even see.
Okay. Thank you so much, ma'am. Maybe when you are less busy, just post them.
Okay, I'll check and post them.
Thank you very much, ma'am. Please, Chiefs,
Thank you.
your contributions. Yes,
Thank you,
Chief.
Chief Alagbe. I don't know. You can see how bulky this guideline is. And I know how super summarized it took extreme stress to go about it. Is it possible to post this your super summary for us? Because they're actually quite extensive to shorten the troubles of going through the whole document again.
It was okay, but if you read this one that is on my slide, that's 2023 AF fibrillation guideline at a glance. Most of what I said, especially these 10 take-home messages, you actually see most of what I said. Then the ones that they bold in, those are the ones that actually they've upgraded or they added. Like, see, for this one, they're talking about the staging now. They said that AF is actually a continuum. So that other classification they don't think is okay. So since is a continuum, so you start from at risk, then you go. So I think this, if you go through these documents, is actually going to help. But again, if I can do that, I'll do that.
Thank you very much.
You're welcome, sir.
And maybe a selective contribution. So on the phone, like she said, if you have the ESC app, you can quickly just do the registration. It will be accepted just immediately. And once you have that, there is an option to do downloads that you can actually use offline. The difficulty is that you can extract the PDF. That's a summary of the current guidelines for most of the topics, from endocarditis, from atrial fibrillation, from the cardiomyopathies with the new addition. So it's just bullets and summaries. So that one is shorter, and there isn't elaborate reading like the whole PDF. Otherwise, I think that's probably one of the easiest way of because these some of the guidelines are new. I mean, I tried even searching for a well summarized like version PowerPoints online. It's difficult, but when you have the app, the ESC app, you should be able to get all that.
Okay, thank you, Dr. Prince. So, Dr. Uzuki, maybe that's another one. Maybe you can get the ESC, then you just read this 10 take-home message and just see the ones they upgraded.
Okay, thank you.
Yes, these ones that they are bolding, they are the ones that they upgraded or they added. So those are the things you just look at. But I think this summary is okay. Oh, that's what I've always read and know. If not because of the presentation, I had to go deeper.
Okay. Please, are there further comments? Thank you, Dr. Prince, for that. Okay, so from the chat box, thank you, Chief Alagbe. Good presentation. Thank you. It's a lot of work. So, Dr. Alagbe, once again, we are all sincerely very, very grateful. Chief, are there any other contributions? Okay, so Dr. Alagbe, once again, thank you so much. We are indeed very grateful for everything that you've taken us through tonight. It's a whole lot of work. Thank you, ma. I know that we'll be hearing your voice in our clip, or if they ask us in the exam, we should be able to recollect more than 70% of it. At the beginning, I said that there will be 3 presentations, but now time is far gone. Then the third person is not able to join. However, he has already posted the summary of the pulmonary embolism guideline on the group. So she was just supposed to take a recap so that what to concentrate on, what has changed, the low risk intermediate and the high risk in pulmonary embolism. But she's not able to join. I doubt we'll be able to take that again. So by and large, I think that's all.